Hello, everyone, and welcome to our latest installment of Future Direction of Lab Medicine. Today's webinar is called Streamlining Lab Visits. Can patient self-collected blood improve the phlebotomy experience? I'm Dr. Linda Hasadri, the director of the Molecular Technologies Laboratory and a consultant within the Division of Laboratory Genetics and Genomics here at Mayo Clinic in Rochester. And I have the pleasure of introducing our presenters today. Who are Dr. Jeff Mewson, an assistant professor of laboratory medicine and pathology in the Division of Clinical Chemistry, as well as Nathaniel Lexvold, who is an outpatient laboratory supervisor in the Department of Laboratory Medicine and Pathology as well. And both presenters are from Mayo Clinic in Rochester, Minnesota. And with that, I'll now turn things over to our speakers.
Thank you so much, Dr. Hasadri. So my name is Jeff Mewson. And today we're excited to talk to you about streamlining lab visits. Can patient self-collected blood improve the phlebotomy experience? Unfortunately, I have no disclosures and no conflicts, and same for my colleague, Nate. My name's Jeff. As Dr. Hasadri said, I've actually been here at Mayo Clinic for the last 16 years. I'm a clinical chemist, and I'm a director for our outpatient laboratory services and a new up-and-coming group we've created called Remote Laboratory Services, as well as our special chemistry area. Since transplanting from Wisconsin to Minnesota, I've learned that hockey reigns here, and I spend quite a bit of time chasing our three boys around the rink. I'll turn it over to Nate to introduce himself.
Right. Thank you, Dr. Mewson. My name is Nathaniel Lexvold. Been in Mayo 26 years. 19 of those years have been in lab services. I've been inpatient and outpatient, but currently I'm an outpatient lab supervisor that our lab collects from oncology, transplant, and OBGYN patients and fertility patients. And I enjoy my family time, and growing up in Minnesota, I have to cheer with the Gophers, so that river rivalry that we got going on. So,
Thanks, Nate.
All right, we'll be going over in this today is a table of contents. Section 1 will introduce the concept of self-collected blood, and then we'll go over the overview of self-collected blood devices, and then we'll talk about our Mayo's experiences with all 4 products that we've been able to do, and then we'll end with questions and discussions today. And some learning objectives that we want to kind of accomplish today is, number 1 is describe the principles and clinical implications of self-collected blood sampling, including distinctions between the capillary and the venous collection methods. And number 2 is compare home-based versus clinical-based collection workflows with the emphasis on delaying processing and sample stability during shipping. And then the third is to identify use cases for FDA-cleared self-collection devices as alternatives to traditional outpatient phlebotomy. And next we'll have Dr. Mewson talk about lab medicine, starting with phlebotomy.
Yeah. So this is normally a lab medicine series, and we all are familiar with this stat that we throw around as laboratorians, that labs support 70% of all clinical decision-making. I think it might even be higher. But there's very established workflows, and Nate and I live in this world of phlebotomy where we talk about how we have a standard. The provider has to order the test. Then we have to schedule the patient to come in and get their blood collected, has to get back to the lab, get a result, all before they have their appointment, at which point they may discuss these laboratory findings, prepare some sort of plan, and possibly even need additional testing to continue on. So then we go back to having to collect the patient. If you're lucky, maybe there's residual specimen and the timing works out that we can do an add-on. But oftentimes that's not the case. And we're all familiar with these workflows. They've been going on for decades and decades. And then about 5 years ago, things changed rapidly. And I believe we've all come to the conclusion that it's here to stay. So pulling some data from a report that we have cited down here, in January of 2020, 99% of all healthcare was done in person, with 1% being telemedicine, either by the interacting over the phone or by video calls, sometimes even by mail, as would work. However, by the time April 2020 came along, that number had switched to 50-50. And now, just to be clear, when we talk about telehealth or telemedicine, we're saying any services provided when the patient and the provider aren't in the same location. And this rise in demand obviously happened due to the pandemic. However, we've certainly moved past that now, and we're in a comfortable place. However, we see that telemedicine stays somewhere around 40%, according to this journal article from 2024. So we continue to use telecare, and there's been a lot of advantages that have been laid out both to the patients and to the providers. They like having this improved access to care. The patient can be met where they are without having to travel so much. It's actually cheaper in a lot of ways, less overhead. And the convenience factor, I think, has really advanced in a lot of places in our personal lives and consumer habits, that their patients are now expecting healthcare to be able to meet them when and where they want. So, like we just said, it's a very positive experience, not only for the patients, but also providers. There's been surveys out that show that providers actually appreciate the added flexibility of being able to see patients by remote, and the reduced overhead costs for office space, et cetera. Patients like not having to wait in the waiting room before they can talk to their doctor. And they're able to oftentimes involve family, that maybe if they don't live in the same area, they can have multiple calls merged so that you can attend a consult with your aging parents, and they can minimize travel time. So a lot of this increase in telehealth has been facilitated by lifted restrictions. It used to be very hard for us to do these things because you couldn't bill for it, and there were license and regulation concerns. A lot of that changed following the pandemic, and a lot of those changes are staying. And the percentage of hospitals now offering telehealth services, it seems to have plateaued somewhere around 85% or higher. At our own practice at Mayo Clinic in Rochester, we have 20% of all appointments are virtual now, and that continues to grow at about a 2% per year rate. So, as we said from the beginning, telehealth appears to be here to stay. So that brings us to a bit of a gap. How can we in lab medicine adapt to telehealth? Telephlebotomy doesn't really exist. There are mobile phlebotomy programs where we collect blood specimen at the patient's home or maybe place of business or nearby to them at a assisted living center, et cetera. Those are good because they reduce the exposure of maybe some vulnerable patients having to come down to the hospital or the clinic. There's increased privacy and comfort for the patient, and obviously convenience. The challenge that we don't even have to say is that it costs a lot. You have to outfit your phlebotomy staff with a fleet of vehicles so that they can have the supplies they need on hand, including centrifuges and refrigerators. They have to spend time on the road getting to the various places. And beyond that, there's costs associated with liability. Who's responsible if the phlebotomist knocks over their priceless heirloom vase or has an altercation with the dog or the neighbor? All kinds of issues, and even in the environment. So we do have mobile phlebotomy services today. It's limited to those that qualify as homebound for Medicare as far as reimbursement and capabilities. And then there's also pay out of pocket mobile phlebotomy services that are really starting to gain traction. But an alternative to this mobile phlebotomist could potentially be patients collecting their own blood at home and then mailing that back to the laboratory for testing. So this could potentially offset appointments, reduce the phlebotomy burden as far as how often we have to find phlebotomists to go out there and help patients, and still maintain that increased patient convenience. With that, I'll kick it over to Nate.
Yeah, so as we talk about those patients self-collecting blood samples, it's already here. Patients are increasingly accustomed now to having that since the pandemic. A lot of the electronic monitors, the glucoses machines, the heart rhythm machines, blood pressure machines, all of those are the capabilities of doing self-testing at home within the comfort of their space of where they're at, which kind of talks to what Dr. Musin said before about all those expenses and limitations that they have of having to go to the facility. There's also self-swabs with strep, flu, COVID, STI, and then there's capillary finger strips. So at-home testing options still do remain limited, though, but they are here at this present time. Next, we kind of talk about is home collect versus clinic collect. What does that really look like? Can patients self-collect at home and testing be performed at a clinical laboratory? Self-collections. So patient instructions will be crucial in this because at that moment they're doing their self-collect versus a phlebotomist or another healthcare worker perform that lab draw or collection in the hospital setting, and the potential support by phone or web. Is there going to be instruction? What kind of instructions do they look like? Is it going to be audio? Is it going to be able to attach to a live person? How does that look like for self-collection when you're looking at the instructions? And then there's a shipping aspect. Samples need to be stable for 24 to 48 hours. Then also a courier service needs to be established. The other thing about shipping is that there's a variety of environments where patients live, whether there's extreme, hot or cold. Have to look at that aspect of can they stay stable for that amount of time to reach the laboratory to be a good sample. Another thing to think about is delayed processing. Patients don't have centrifuges to separate the cells that are needed to be able to stabilize those. So we need to then look at how does that delay it? What do we kind of need to take precautions to make sure that the sample stays viable to get to the lab? And then studies need to confirm potential impact on testing. This is also a very important part of that to make sure that we are getting the best process we can for the patients for self-collect or home collect.
I lost my mute button. The last thing we need to think about is the different sample, thanks Nate, the different sample type between phlebotomy and capillary collection. So they're very different types. Phlebotomy actually has a minimal tissue injury. People worry about the needle poke and the pain involved, but it doesn't harm you much. And it's able to get a very clean sample of blood. Primarily venous, you can do arterial sticks as well. And we know exactly what that is. We're going into a vessel, we know what the vessel's a vein, or we know the vessel's an artery, and we're getting almost entirely pure blood. Low risk of contamination. There's special issues we all have to think about once in a while in phlebotomy that pertain from order of draw or fist clenching. It could cause things, or IVs, but typically very low risk of contamination. Capillary is a different beast. There's a lot more tissue injury because you're drawing right at the site and sometimes even squeezing or trying to milk some sample out of the tissue where you've done the pierce, the lancet. And then you're also activating a lot of clotting factors. The fluid that you're collecting is a mixture of capillary blood, which isn't venous or arterial. It's something in between. Plus, it's the interstitial fluid from your skin or your skin pad. And so it's really a much less clean, much less well-defined matrix for us to do testing in. And so just from that aspect alone, biomarkers that we're used to measuring could have very different concentrations in capillary versus venous blood, which means we'll need to look at what possible new reference intervals are involved or expectations for precision of a given test or bias that might be involved. I keep losing my mouse. All right, so we had a few devices. Is this one back to you, Nate?
Yes, sir. So, yep, in no particular order, we're going to go through the 4 devices. The first one is the BD Mini Draw Capillary Blood Collection System. The intended use is for in-clinic by a healthcare worker, whether that's a trained phlebotomist or a nurse or whatever form of healthcare worker that may be stationed at their location. It's a capillary collection, uses a standard lancet, BD lancet, and then the tubes that they use for this is an SST or an H&H tube, which is also known as an EDTA tube. The instructions are capable of being given via electronic device, so it can be given as a stop and go. So as you progress through the process, you'll be able to pause it and do that step, pause it again, perform the step, and then pause it again. So it is able to go at the speed of the patient, which is one of the critical things for the fact that not everyone can take instruction and receive instructions all at the same time or at the same level. So the next one would be the red drop. This is also self-collection. This is a self-collection device, which is a capillary collection device. It has a built-in one-time use lancet with the attached microtube on the bottom, as you see where the thumb is located on the picture. That is where the tube will be placed. The next, the one will be the tassel device. It is also a self-collection device, capillary collection device. It also has a one-time built-in use an attached microtube at the bottom. And then the next one will be your bio, which is another self-collection device. Capillary, built-in one-time use lancet, and then it's attached at the end there. As you've noticed, all three of them are very similar. So we're going to kind of go through the process of the three that we talked about, the tassel, your bio, and Druid drop, and what they kind of all share in design elements. As you see, adhesive is at the top. So the initial placement is at using adhesive to the skin in the shoulder area. So all three of them do that. And then the next is a lancet. So it's a blades or a micro needle in all three. And the depths are a 0.8 to a 3.0 depth for each individual one. It can be one of the varieties within that frame. And then the plunger. As you see, all of them have a certain type of plunger. There's a blue, a red circle, or a red lever. All of them will need to be activated, and is a general vacuum that uses it. So once they activate it, that vacuum helps bring that blood to the surface to be able to get that collection. And then also the tube port. It's vendor neutral, so it allows it for any tubes to be put on there, not specific to any one particular type of tube. Okay, so then we talk about the actual self-collection process. The instructions, these are similar instructions for all three varieties. The unpackage and attach to the tube. Important part to make sure the tube is seated on correctly. So that's one part that we do in part one. Next is apply the heat back, and each device can go anywhere between 2 to 5 minutes. You're going to attach the heat back to the area that you intend to place the adhesive self-collection device. And then number 3 is you're going to peel the adhesive and apply it to the arm. As we talk a little bit later, though, there is a location and placement of the device is something that we've noticed that can be a particular critical point in it. Number 4 is the pressing button and set the timer. So number 4, each of them you have to press a button. You usually hear some sort of an audible click, and then the timer is set because they are looking to have it collected within a certain amount of time, anywhere from 3 to 5 minutes. Once we go down to number 5, we want to allow that tube to fill. And we want that within the 3 to 5 minutes. The reason why is because we want to make sure that there's no clotting that happens due to the longevity of having to collect for the collection of the sample. But we want to be able to look down and see that it gets above the line that we want on each tube that there is. They're usually very well marked. And then number 6, we're going to take off the device off the arm and then remove the tube from the device. And then number 7, we're going to cap and invert. So we want to do our inversions, just as we do with any of our other samples in phlebotomy. We want to do our correct inversions to make sure that we get any additive that's in the tube correctly mixed with the sample. And then number 8, we're going to record the date, time, and place in the bag. This is going to help when we get to the processing part of knowing when and when it was collected for sample.
Yeah, so we did a number of different studies, and you can see, I mean, those 8 different steps are pretty intense. And that's a lot to ask of a patient. So before we sent this to patients at home and asked them to go through it, we decided to do some studies here at Mayo. And the basic design of the study would be we would have patients come in for a venipuncture appointment, and then we'd provide them one of the kits and ask them to collect their own blood with a phlebotomist present there in the room. So Nate personally helped dozens of patients do this, as well as his team, in order for us to just get an idea of how would this work if we were to implement this for routine clinical care. As Nate pointed out, these devices are FDA approved, so theoretically they could just be used on their own without any extensive validations, et cetera, but we wanted to make sure that it was going to work in our clinical workflows. So as we say here, we actually had 2 different study types. The first, we were collecting whole blood EDTA. We were either drawing patients that had an immunosuppressant clinically ordered or a CBC, and then we were asking them after having had their venipuncture, would you use one of these devices? Going forward, we're not going to call out which device we used in each study, but it's of those 3 that we just mentioned. The BD one that we mentioned first, the studies are still ongoing, so we're not ready to share those data just yet. The other study we're going to talk about today is when we would look for serum testing. We brought in quite a few volunteers for this. to determine if they could collect a serum sample, again, paired with a venipuncture.
So phlebotomist impressions, we were able to have our lab staff here in Charlton help with the majority of these and a lot of these patients, be able to walk through them. And it was nice to get some of the feedback of what the phlebotomist said. This is what they do every day. So being able to kind of go through these is be able to see what, from a phlebotomist aspect, what it's like. So being able to help with these different capillary devices has been a positive experience for the patients. The patients see that the potential that this collection process can help in their daily lives. I think that's a really one big one that our staff has really noticed is that they can see, and the patients are kind of commenting on the fact that, wow, this could really help me in my day-to-day life, not, being able to eliminate some of that overhead, like Dr. Newsom said, and even for the patient of parking a car, paying for parking, all that stuff that involves going to the doctor or going to get their blood drawn. Next comment was these devices could really help some of the different patient populations that we draw blood from here. So the phlebotomist noticed that, hey, the populations that we're seeing here, this could really help. And if we can see how this study goes and see how this works, we could really see that the potential is there to help a lot of different types of patients. The ease of collection allows it to be collected from many different types of environments, including the patient's homes. That was another great comment that I thought was great to hear, to be able to just understand that patients come from a lot of different areas, come from a lot of different regions, and they have a lot of different living situations. Being able to have that capability and variety of being able to collect is definitely an essential part of making this successful. We also, in the patient experience, want to give a short survey. We wanted to gauge the clarity of instruction, the pain and willingness to use it again. So the first question we asked was the written instructions clear. We used a 1 to 5, with 1 being completely disagree and 5 being completely agree. And everyone knows the pain scale. We used the how would you rate the level of pain experience when the button was pressed on the device and your collection began. And we once again went from no pain to 0 to unimaginable and unspeakable pain. So we were able to really gauge the different level of faces there to see where it's at for that each individual patient that we worked with. And then the third one was, I would use this device again in the future to collect blood for self-sampling testing. Looking to say, hey, I enjoyed this experience. I would be open to using again from completely disagree 1 to 5 to completely agree.
Yeah, so this is combined data from all the 220 some patients that we worked with. Nate's team sat through all the extra time that, it took about 10, 15 minutes, would you say, for the patient to run through the process. So it lengthened some of our outpatient appointments. And these are now the survey results we got. Most people thought the instructions were clear. Some people struggled with it. And it's obvious that some of the device manufacturers had better instructions than others. As you can see here, one of the devices really had greater than 80% completely agree. And we have more to talk about that if you want to get into it. Nate went through many iterations with different vendors as we perfected this. Talking about the pain, how do you rate the pain when we click the button? Most patients said there was no pain, or it was very mild, or just slightly discomforting. I personally used all 3 of these devices because I wanted to know what we were asking our patients to do. And most of the time, I wondered if I actually did it right because I didn't notice anything when it happened. So I do think they're very painless. And I think that bears out here with the patient data. And there wasn't a big difference between any of the devices. They're all down into the discomforting or no pain at all. Your eyes being drawn to the outliers. There were 2 patients with 2 different devices that said that it was the most unspeakable, unimaginable pain they've ever experienced. One of those patients put in a comment saying that it was very painful, they did not like, they wouldn't do it again. The other patient said they still prefer it over phlebotomy. So what that means, I don't know. If phlebotomy must be even more painful to them, or they didn't understand where they were supposed to put the mark, not certain, but take that for what you will. And then on that third survey question, we'll get into, would patients self-collect again? Most people said they would. A little more spread here than with some of the others, but most patients, again, more than 50% said they would be willing to try this again. should the opportunity arise.
And then we kind of come to comments from the patients, which is, I had the unfortunate ability to be in the room with the patients and hear this and be able to collect this data, which was part of my job that I enjoy. One of the patients said it was easy to use. And another one said, will be helpful for patients needing routine labs. And then the video helped a lot, as Dr. Musin referred to. There was many iterations of instructions, and one part of it was being able to use that video. Some were paper instructions, some were video instructions. So once we got the video, it definitely helped them a lot to be able to be successful in performing the task. Very technical, could be difficult for people who have difficulty following technical instructions. As Dr. Musin mentioned before, also is that those instructions were very stepped out, technical. So for some patient, there was that aspect of, can we get through all of it? And we were there as lab staff to guide if there was any questions. We wanted the patients to be able to do this on themselves, but we are also there to make sure that if they did have questions, they weren't left alone. We were right there with them to be able to help out. Another patient stated, quite simple procedure. And the last one we had here is, would make blood collection very convenient for me since I could potentially do this from my home, which was a great comment to hear, for the fact that this is, as we know, that telehealth is here. And if they're able to collect it from the home and send in the sample and then have that telehealth appointment with their doctor in the next couple of days, that is something that's potential is there for.
So then patients liked it. Lab staff found that it was, they could see the benefit to it. How did it work? So step one was, how often do we get a usable blood sample? Breaking it down into the two arms of the study. In one arm, we were looking to collect an SST tube so that we could do some serum chemistries. We only used device 1 and device 2, and they had a fail rate of between 15 and 17%. When we say fail rate, we say short volume, meaning we didn't collect enough blood into the device for us to be able to do any chemistry testing. And that did happen. Nate, I don't know if you have comments on how you feel like it would go sometimes when we had these short volume situations.
Yeah, most definitely. We'd have them, and sometimes the patient was like, well, did I do something wrong? And sometimes it's, nope, you did exactly right. It's just, sometimes it's a condition of the patient, what they're being seen for, what the condition they're coming in, if they've had a lot of testing or treatments. So definitely having that aspect play into it is one of those that we definitely saw here.
Yeah. And it was consistent over those two devices for that study. And then all three devices in our second study, where we were going for an EDTA blood sample, again, in that 15 to 20% fail rate. So it seemed that you'd either get 1 or 2 drops or nothing at all, or you'd fill the tube. Is that a fair assessment?
Most definitely. It seemed like there was a feast or famine on that.
Yeah, feast or famine. So for why didn't it work? It might have been patient specific. It might have been following the instructions. We're not certain, but it's a consistent risk. So you're only going to get a successful serum sample or any blood at all, about 85% of attempts. The other concern we noted, particularly when we were going for EDTA whole blood, was that these samples clotted. Those of you in the blood collection business will know that EDTA collected in a microtainer from capillary collection tends to clot anyway, but we were shocked at how often these clotted, despite even filling the tube. So set aside the 15% of the time it wasn't going to give us anything in the tube. The rest of the time, it seemed like between 40 to 80% of the samples would be clotted by the time we got it to the laboratory. We spent a lot of time troubleshooting here. We attempted different fill rates, different heat packs, change the order in which we asked the patient to invert the tube. So basically, before you do anything else, just pull that tube off and quickly start the inversion. And it just seemed that this is really a limitation of these devices. And we've decided it must have to do with the tissue injury involved when you collect from the capillary, even though it doesn't seem to have much pain. So lessons learned.
Yeah, so some of the lessons learned, as we alluded to before, is a lot of different trials and errors that we did. So the instructions, we had paper, we had electronic, we had a video, and we started off with one video, and then we're like, we got some feedback from the patients. We're like, can we slow this down? Even the video was a little fast. So then we asked them to slow it down. They broke it up in pieces, so that the patients helped a lot better. So having that immediate patient feedback and phlebotomy feedback, having the phlebotomist in the room really helped us through the trials and errors of how can we make this better? How can we make this more successful, or at least to make sure that we're getting the accurate data that we can. Heat pack is another area that we definitely looked at, types and timing. So we tried a different couple of heat packs, and then also the timing of it. We started off by 3 minutes, we went up to 4, we've gone to 5 minutes. Just see what is the optimal timing. Are we getting any results? And just see what the EDTA results between 3 to 5. We're still seeing the same as within that collection of data that we have on that previous slide. Another one lesson learned is that device placement and location was very important. Device placement on the spot where it is heated was essential, and the other part of that is making sure that the device was straight up and down. And the instructions stated that, but if you ever put anything on your shoulder before, you feel like it is straight up and down, but it's not necessary. So being able to see that on the first couple, and we're having short samples, we were able to say, okay, we need to make sure that it is straightened up. So that's one of the things that we made sure that was emphasized to see if that would help us with any of that, making sure that we get a good sample. Then, like I stated before, positioning the device on the heat location. Sometimes it'd be off and like, okay, we didn't hit the exact heat location. That could be something that we need to make sure that we're doing. And then listening for the click. As Dr. Musin has stated that when he did it on himself, he hardly felt anything. So the patients really had to listen for the click to make sure that it was activated. Otherwise, because they're not getting the sensation of a puncture like a normal venipuncture would, where you can maybe feel it go in, these devices are so well that they don't even feel it, so that they have to make sure you hear that click to make sure that is activated, to make sure we're collecting a sample. So those are some of the lessons learned throughout the different studies and the study time frame.
Yeah, so we wanted to leave some time for questions. So wrapping it up on our final thoughts, they're very patient friendly. So the companies are being truthful when they say patients love it, because they do in our experience. Minimal pain, high satisfaction. I agree, there's very strong potential. We think that patients liked them. It does yield adequate sample when it works. But there are some concerns that need to be dealt with specimen integrity. That clotting for whole blood, and then that 15% of QNS, or quantity not sufficient, was something we need to work on before we can really deploy this widely in routine care. We also want to make a special thanks to our fellow, Chelsea Swarchik, who did a lot of work here, Laura Price, who works closely with Nathan in the Charlton Outpatient Lab Services area, and Troy Toole, who is our manager in charge of remote lab services, hoping to deploy this soon. With that, we'd be happy to field any questions you may have.
Any questions that you, our audience, may have. Again, you can use the Q&A icon in Zoom to submit your questions. So going ahead and pulling that up, we have a few already entered in here. So first question is, are these for a single test only? CBC and Chem would require 2 devices?
Good question. They all, as you saw, they all accommodate a tube. We're a BD shop, so we use BD microtainers on them, but it will only take 1 tube. So if it's either got to be a serum, a plasma, or an EDTA whole blood, you choose.
Right. Thank you for that. Next question is, how well does this work on heavier set individuals?
Looking at that aspect, I mean, we definitely had all size individuals, or patients. So it didn't really seem on the size that mattered to the patient. It was more the patient condition and placement and some of the lessons learned. It really depended on that than rather any particular size of the patient. So it's definitely making sure we have the correct location with the heat pack, making sure it's staying on there long enough, devices straight up and down.
There were some mobility concerns, right? If patients could actually reach all the way over and then see what they were doing.
True. Yep. And that kind of played into making sure that the device was straight up and down. It definitely was that aspect of mobility concerns. Yes.
And that's why we wanted to try both normal volunteers who as laboratorians, we all volunteer all the time and get stuck in our own labs and our own things. But then we also intentionally sought after some patients that we thought would have the most benefit, which is our transplant patients that are constantly having to check their immunosuppressant levels. And I thought we saw more failures in that group, likely due to just overall less healthy situation. So it was struggling to push the button or activate the plunger, maybe less circulation in general.
Thank you. All right, next question. Lots of audience engagement today. How would this help the older population? Since they are more challenged for travel, would they be able to use this device?
Nate, what do you think?
I think I think they definitely could use this device. I also feel that there is the mobility issue of being able to reach all the way over that may hinder that population, and that could be any population. But I do feel that it can be used. I mean, we had a variety of patient ages, so I think the capability is there, the potential is there to be able to use it in all different age levels.
Yeah. Especially if they have family or friends nearby that, it doesn't necessarily have to be them doing it. It could be somebody else walking them through it.
Yeah.
Or assisting.
Next question is, in your experience, would any of these devices be appropriate for collecting a pediatric patient?
They did sneak one picture in there. There's been 2 big studies that I'm aware of. The companies do advocate that there are no age restrictions on their FDA approval. So they can be used in pediatric populations. And there's 2 studies where they did so. They found decent results. They would either apply it to the lower back of a child or onto the thigh of like a younger toddler infant age, kind of where you would do vaccinations on the upper lower limb. So they were able to collect adequate sample and do testing. My biggest concern is our number one ask for capillary collections in pediatrics is CBCs and lead testing, which would be whole blood samples. And try as we might, Nate and I, went through so many iterations, so many devices, so many instruction changes. The clotting rate on those EDTA whole blood samples was too much for me to want to start using these in a pediatric population just yet.
Thank you for that information.
Yeah, Nate, do you have any follow-up considerations? Haven't been in the room with the patients?
Yeah, definitely. I mean, and looking at the pediatric aspect is also, as you know, if you worked with pediatrics before, the patient definitely plays a part. Pediatric holds. How does the patient respond to vena punctures already? Definitely, this could be a good possibility of on the back or on the thigh. You have your distraction method, so definitely something to think about potentially.
Thank you also for that. A comment and a question for our next one. Interesting info. Our lab has been working to minimize the amount of capillary samples due to the poor quality of the sample. With the study over, where does Mayo see this going?
I think it'll have to be targeted. Like I said, we wanted to be able to use this to help our patients that are on immunosuppressive drugs, but the clotting issue is going to prevent that. Other scenarios, if this could offset an entire outpatient phlebotomy appointment, then it would be worth doing. The data that we didn't actually take the time to get into on the chemistries, nobody will be surprised to know that glucose and potassium don't do well when you do capillary collections with delayed processing. So by allowing the sample to sit for 24 to 48 hours to simulate shipping before it could be centrifuged, then we're not going to be able to do basic metabolic panels. So there is a restriction there. We'll have to do some more thinking on what specific applications that are ordered frequently but in isolation that we could offset an outpatient phlebotomy appointment. So we have some ideas, things like PSA or other cancer markers where that might be the only test that's ordered and it's requiring a patient to come in for an outpatient phlebotomy appointment. We could offset it with one of these tests, but we'd have to validate that those markers work.
Next question is, did you evaluate the BD mini draw device?
We are ongoing. Nate's actually still working on that one.
Yep, we're currently still performing that one. So once we have completed that, there will be an evaluation looking at the results and looking at the comparability of what that looks like for the overall project.
Yeah. So a stack of them in the lab, and patients are using them as we speak. We hope to have more data by now, but it's not how it worked out.
Very relatable. Next question is, how would the timely return of specimens be addressed? Would the chems be spun by the courier?
All these options were considered. And again, this is why we went back to whole blood being what we thought would be the best. You don't have to worry about freezing it. In fact, you want it not to be frozen, and you don't have to centrifuge, but clotting prevented that from being useful. It's possible if we arrange with a courier that you could have it centrifuged prior, but it kind of defeats the whole purpose of us trying to make this involve less medical persons. So right now we're simply looking for analytes that aren't affected by prolonged sitting on the cells. So we've been looking into cancer markers, like I mentioned. PSA seems pretty strong. You won't be surprised probably to learn that creatinine can sit on the cells a lot longer than we expected. It's just outside our comfort zone because as laboratorians, we've always thought you need to spin the cells off as soon as you can. So we never bothered really, I think, at least we hadn't in our lab, bothered validating how long could you let it sit on the cells before it affects results. So we're doing those studies now.
Next question is, are these all newer to market devices or have they existed for some time now?
I think around 2020, 2021 is when they got their FDA approvals. There's been iterations though. So some of them, it's the second or third generation of the device that we are working with, and they keep telling us, okay, the next one's going to be the one. So, and I agree, I believe it. I think it might be. Early devices, they couldn't hardly collect enough sample. Now it seems that we've gotten past the sample volume issue, but now we have a clotting issue. Different devices have different numbers of lancets so some of them use up to 13 different little microneedles, and some just use one lancet that goes a little deeper. And all these different strategies are trying to figure out what's going to get us the best specimen.
So the next question is, if you wouldn't mind letting folks know again what the exact chemistry tests you were performing were, such as glucose.
Yeah, we did tacrolimus, and we found that it actually, in the samples where we got a specimen, which was less than half, it actually compared very well between venous and capillary. There was a slight bias, but that was expected according to our forensic toxicology specialist that knew that there would be a slight bias between capillary versus venous sampling. So tacrolimus, and likely if we were to take that further, sirolimus and the other immunosuppressants would work. We then did the basic metabolic panel and found most of those analytes do all right. The exception being bicarb, which is very pH dependent, potassium and glucose did not do as well. And then we were also, like I said, looking at some cancer markers, but that study is still ongoing.
The next question is actually a few questions bundled into one submission. So let me know if you need me to reread any parts of this. But we start off with, how about logistics for a patient's self-collected specimen? Homebound patients sending a courier, would that be viable to still maintain specimen integrity? Or is the best case scenario that the patient or family member has to drop off the self-collected specimen for processing/testing within X hours after collection? If having to drop off and a venous specimen is preferred, why not just have the venipuncture completed that as a quick visit? Or sorry, as that is a quick visit. So
I feel like it's asked and answered. Nate, do you have any other thoughts there on how we'd get the specimen back better?
Yeah, I mean, I think you're exactly right. Asked and answered, but the aspect there's a lot of different parts to that. There's a lot of moving parts with shipping, with being in the collection. How easy is it collected? How easy is it for the patient or the patient family member to bring it back or to get it shipped? I think there's a lot of different components that is sometimes outside of our ability to control, and so we're trying to make it best for the best case scenario on whatever situation the patient may be in.
Yep.
Thank
And
you.
while outpatient phlebotomy appointments can be quick, as those that work in the space know, we have a certain number of appointments a day, and we typically draw quite a few more patients than the appointments we have on our calendars. Just
Correct.
the way it is.
Great,
Nate
next
wasn't going to bring that up though, because he's too stoic about it all.
All right, next question is, I missed another presentation due to staffing in, but was there an internal validation of results with traditional phlebotomy along with the capillary levels on site?
Yes, we did do that. And like I said, and I guess I didn't expect there would be so much interest in the actual values. I thought people would be more interested in the process and the logistics, so we could have shared these data. The basic metabolic panel works pretty good. We even simulated not just letting the capillary sample sit for 48 hours, but for it sitting in extreme temperatures, just to see what would happen if somebody left it in the trunk of their car in a Minnesota winter or an Arizona summer. And we found some analytes do well. Creatinine feels like you could boil it and it probably would still be measurable at the same concentration. The electrolytes didn't do as well. Glucose, potassium definitely fell apart. Other things that are commonly ordered that we looked at would be like a PSA or a TSH. Those seem to do pretty well. Again, it's going to come down to, though, if you can only get part of what would have been ordered, then you're not offsetting a phlebotomy appointment anyway. So we're going to have to look into ordering patterns to see what makes sense.
All right, another one in the vein of, or in the same vein of, pun intended, sample stability. Just wondering if you have reviewed or tested transportation requirements of specimens.
So we have looked into how long it takes a specimen to get to us. Is that, you think, where they're getting at here? So we know that we can get a specimen that was collected by, say, a third-party phlebotomist somewhere in the nation to our lab in Rochester within 36 to 48 hours. So that's why we have decided anything we're going to validate, it needs to be stable 48 hours. FDA has a few suggested temperature cycling studies they would like to see people do to show that during that 48 hours, if and this is not just the specimen, but the entire container the specimen is in, is exposed to extreme temperatures like 40 degrees Celsius and -10 degrees Celsius for up to 8 hours, does the sample still recover? We're in the process of doing those studies, and we'll see what we see.
Right, you'd already spoken to the viability of these devices on pediatric patients, so I'll skip to the next question, which is, how will this work for inpatients needing blood draws?
Nate, do you have any thoughts there for us?
Looking at the inpatient aspect, if you were to be able to distribute it out to an inpatient unit, be like, okay, we need this collected. Maybe the nurse or a PCA or another healthcare worker could help provide that aspect. Which could that eliminate some of the draws that a phlebotomist would have to go in? It could streamline both efforts. Some of the fact that that patient can get taken care of while another one is taken care of by the phlebotomist. There is that aspect and something that could be looked at. That's the first thing that comes to my head on the aspect of how could it work for an inpatient setting.
Yeah, and the companies even proposed to us, what if you had nurses do this or even clinical assistants in an outpatient clinic setting where they're sitting you and you're waiting for your doctor or for the vaccine part of your appointment or something like that. So yeah, I guess there's possibilities there, but it comes back down to the one tube type and 85% success rate. as opposed to Nate's group, which is a 99.999% success rate.
Next question is, would clotting disorders disqualify patients for this option?
I don't think we had any exclusion criteria, did we, Nate?
Nope, nothing like that. Mm-mm.
Mm,
Okay, I just think for the fact that we did see a lot of clotting, and I don't think there's no exclusionary, but we still had that clotting aspect. So, there's definitely something to think about.
Yeah. And the clotting occurred both in normal donors and in patients, similar rates. And we didn't have any events of people with excessive bruising or uncontrollable bleeding afterwards. So, but that is a good question that we could probably dig into the data a little more and see what percentage of our patients might have been on any kind of anticoagulant therapy.
Next question is, how do you ensure time of collection to time return to the lab is within stability guidelines?
Yep. So those of you that maybe allow patients to collect other samples, be they swabs or urine samples, et cetera, off-site, we ask the patient to write down when was this collected on some paperwork or the bag or the container or something. And most of the time they do that, but not all the time. So it's going to be part of the issue of when was it actually collected versus when we had it in hand.
Next question is, and you'd mentioned earlier instances where you didn't get sufficient volume, but this one is any issues of just not getting a blood flow at all, even if instructions were followed properly?
We definitely had that aspect where to us as phlebotomists, we're standing in a room, we're watching the patient. They're doing everything that they needed to do, and we're still not getting anything. There was those times where we had that, and it's one of those. It's like, okay, well, we followed everything. We just kind of did our check marks and benchmarks of what we needed to do. Patient did it, and we still didn't receive a sample for that. So I mean, we still sent that on and made sure that we noticed that we wrote any comments or remarks on our part, even as phlebotomists, noticing that everything went well with the actual collection part, but we still did not receive a sample for unknown reasons, to us.
Yeah, and a lot of times you'd say, you even saw the little mark there.
Yeah.
It did nick the skin, but we got nothing.
Along those lines, then the next question is, have you considered automated robotic phlebotomy?
We have. We're in talks with several different vendors which are working on that. There are no FDA-approved solutions currently in the United States, but there are at least there's one group and possibly a second that are moving towards having a commercially available product. And Mayo Clinic would most certainly want to evaluate those.
Ooh, the next question, good one here. How would the patient determine where to set the depth for the lancet?
So for the depth that we had, the patient necessarily is not setting the depth, is a preset depth. So once they hit the plunger on it, the depth is already set per the device. Now the devices maybe had different depth size or depth lengths, and also whether it's a microblade or a single lancet. But it's predetermined, nothing that the patient actually has to set. It's just press the button or click the lever, and that will go to the depth that is regulated for that product.
Next one is more of a comment than a question, I think, and it is, transportation requirements could potentially relate to the people who are trained to perform the task. Review cap.
Yep.
And then the next question after that is, we have issues with patients forgetting to properly add date and time info on their specimens. How did patient labeling work out during the study? Was the specimen pre-labeled, or did any patients forget to label the specimen?
Nate, did we ask them to label, or did we handle that part?
We handle that part. So at that part, once the specimen was collected, they inverted, they did that, then they handed it to us, and then we labeled it with the labels that we needed to ensure that we had, when we were doing those side-by-side studies, that we'd have both the labels, we send it to the correct location. So for the studies that were in hospital, or excuse me, in clinic, that is how we handled it. We were able to, as phlebotomists, be able to handle the labeling.
But I can completely relate to the question that was asked because that happens with us all the time.
Yeah.
And we feel like we put bright pink stickers and extra paperwork and signs everywhere that say failure to record collection time may impact our ability to report, and it still gets missed.
Looks like we got one more comment too from the audience, which is, I believe Mayo is already contracted with, and I apologize if I mispronounce this, Vistertro robotic phlebotomy for FDA approval. Is that ringing any bells for either of you?
We have been evaluating. Vitestro is a company that has a robotic phlebotomy system, and it's not FDA approved yet. I believe it's being considered currently. I think it has been publicly announced will be part of a major study, a multi-center major study using those systems, and they will be in our Rochester campus during that time.
Well, that was over 20 questions and comments you both fielded. Do you have any other closing comments or insights you'd like to share with the group?
There's obviously lots of interest, both from us as the healthcare providers, but also from our patients. My biggest concern is a lot of times our practice partners will see the advertisements that are getting targeted to them through social media and commercials online, et cetera, and assume that this is a thing that exists, is vetted, and should be implemented. And I just want to assure everybody that we're all having to do our due diligence, as we do in healthcare in all fields, when we bring it into the clinic for practice. Nate, any other closing thoughts from you?
No, I enjoy helping with the studies, being able to learn and just be able to see the different avenues that healthcare can go, and how telehealth is here now, and how it will melt into the healthcare scene in the future.
Thank you both. And surprise, we actually had one more sneak in. And so in the last couple of minutes, I'll share one more. So I know you had mentioned that you took a close look at the inversion process for the EDTA tubes. Can you share roughly what those instructions were and any modifications you made or suggested along the way?
Nate?
Yeah, so I mean, the instructions that we had were to, as immediately as we can, take the tube off the device and invert, cap it and invert. Some of the instructions waited to put a Band-Aid on, and we're like, well, was that the right thing to do? We modified some of that with the different devices and said we need to get that off because we're seeing that it's clotted. So let's get it off right away and get that cap and get it inverted. We have the standard inversions for all of our lab tests, and so we follow those directions on that because that's the standard that we're adhere to, and that's what we look to. But I'm just trying to think if there's anything else, Dr. Musin, that we did.
You and Laura had that. You got to flick it to break the surface tension. And
yeah, so we did have the flick motion and then inversion. So there was definitely different variation and different options, and that we tried to adjust to and try to minimize the clotting once we kind of started to notice that. So.
All right. Thank you both again, and thank you everyone for participating in today's webinar.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.